Thank you for asking me to talk about kidney cancer. The word kidney itself is sometimes frightening. Anything which happens to the kidney, people are extremely worried about. I'm sure there are three organs in the body, the heart, the kidney and the brain, which actually sets a little bit of anxiety in people's mind whenever something goes wrong with them. Now, the kidney cancer is the commonest cancer in the Western world, and now in India we are seeing more and more number of patients with kidney cancer. Now let us talk about what causes the cancer in the kidney. Traditionally, it has been thought the patients who smoke, patients who use tobacco, patients who have association with the petroleum industry, the cadmium industry, the rubber industry are likely to have more chance of kidney cancer. Now we also found that there are a lot of genetic elements which are predisposing the development of kidney cancers in the community. One of the striking innovation in the past was about finding the gene called as VHL or von Hippel-Lindau gene. When you have a deletion in that gene, which is a VHL gene, people can develop renal cancer. In last 10 years, lot amount of search or research has been done on development of these hereditary renal cancers, familial renal cancers, hypoxia-induced factors which can cause renal cancer. In the good old days, there was a classical triad to diagnose renal cancer, which was patients would have pain in the abdomen, patients would have a palpable mass in the abdomen and would have bleeding in the urine called as hematuria. But when this happens, probably the disease is well advanced and the 5-year survival rate in these kind of patients was very, very low. Thanks to the technology, thanks to the awareness, now we are getting more and more patients in a very early stage. Now, ultrasonography or a CT scan has become a very common investigations for any specific and non-specific symptomatology. Now we are picking up the kidney cancers in a very early stage, as small as something 1 centimeter or 2 centimeter within the kidney. We all know we have two kidneys sitting in the upper part of the abdomen, and both the kidneys can have kidney cancer. Now, how do we diagnose these patients? Once the patient has some pain or bleeding in the urine or incidentally picked up on imaging, the first and foremost thing we do nowadays is to do a 3D CT scan. A CT scan would tell you, or a CAT scan would tell you, the location of the tumor, how big it is, with the extent of the tumor. Sometimes these tumors can be nasty and can involve the venous system, that's the renal vein, and it can extend up to the inferior vena cava and going to the heart as well. And that's why we need to do a CT scan. During CT scan, we also need to know the blood supply of the kidney, the segmental artery which is supplying the blood to that tumor, because when you try and save that kidney, that architecture, that anatomy has to be very well understood on this imaging. We also do a metastatic workup to find out whether the cancer has spread anywhere or not. The big question nowadays is whether we should stick a needle into that mass to diagnose the kidney cancer. It's a debatable issue. Conventionally, most of the CT scans, if they show an enhancement with a contrast and are almost always diagnostic of a kidney cancer, you don't need to do a biopsy, that is sticking needle into the kidney. But if you want to do a nephron sparing surgery, if you want to do alternative therapies like an active surveillance using cryotherapy or HIFU, you can actually sort of take a biopsy from this mass and plan it further. There are certain exceptional situations, like patients who do not have typical appearance of a tumor on a CT scan, then we always do a biopsy. If there are two malignancies in the body, maybe in the lung and maybe in the prostate, and then you find a tumor in the kidney, we want to know what this tumor is all about, so we do the biopsy. If somebody has bilateral tumors, then you want to rule out some sinister condition like lymphomas, and there we stick a needle into this. So wherever there is an unusual situation, when you want to do active surveillance, we then do a biopsy. But 9 out of the 10 times, the CTs are diagnostic and we don't need to do a biopsy in this kind of situation. Now, how do we stage kidney cancer? is by doing a CT scan. It has to have an angiography with it. Renal function tests are also important, liver function tests are important, and also if the patients have symptoms of a spread of the disease, then we do a bone scan and the scans of some other places as well. Now, once you know where the tumor is, the treatment is tailored according to the location, the size, and the stage of the tumor. If the tumor is in one kidney and the contralateral kidney is entirely normal, then we have a choice of removing that entire kidney, which is called as a radical nephrectomy, or with new technology and new innovations, we can still remove only the tumor involved in the kidney, and rest of the kidney can be preserved, which is called as a nephron sparing surgery. Now let us talk about removing the kidney. That's a radical operation. This operation is done for tumors which are more than 6 to 7 centimeters in size. The tumors are still related or limited to the kidney, and they have not spread anywhere else, like into the lungs or a brain or bones. This radical nephrectomy involves removal of the kidney, its covering called as Gerota's fascia, and the hilar lymph nodes and the upper part of the ureter. Now this can be very curative for a stage 1 and stage 2 disease. There is a debate about whether we remove the adrenal gland at the same time, and now we have resorted to the conclusion that unless there is involvement of the adrenal, unless there is suspicion of involvement of the adrenal on a CT scan or large upper polar tumors, we don't usually have to remove the adrenal along with the kidney in each and every situation. As far as lymph nodes are removed, usually the hilar and regional lymph nodes are removed, and still there is a debate about whether we should clear the whole retroperitoneum or not. When we do radical nephrectomy for a stage 1 and stage 2 disease, the 5-year survival rate is in the range of something like 80 to 90%. Now this is radical nephrectomy. Sometimes these tumors can extend or progress into the renal vein, and the infravena cava is the main vein which is draining gold toward the heart. Now if it is below the diaphragm, not going to the heart, then we can still do the radical nephrectomy, that is remove the kidney. We can actually clamp the IVC in the renal vein and remove the entire thrombus, and still patients can have a very good survival. And these patients are technically very challenging. Should be these surgeries done in the tertiary care centers, and these patients can also have an excellent survival. Now if the tumor thrombus is going to the heart, sometimes you have to do a heart-lung bypass surgery, veno-venous bypass surgery, with which you can remove the kidney along with the thrombus, and a thrombus in the going to the right atrium, and still nearly 50% of these patients do extremely well. Now the next thing comes is the tumor is very, very small. If the tumor is about 3 to 4 centimeter size and is situated in the polar region, maybe the upper pole and the mid pole and the lower pole, we do a surgery which is called as a nephron sparing surgery. What is nephron sparing surgery? What we do, we temporarily occlude the blood supply to the kidney. Sometimes we have to cool the kidney by putting it into the ice slush so that the metabolism within the kidney is not affected. Now the clamp time is important. We should do it in as minimum time as possible. So we explore the kidney, we explore the vasculature, that is the artery and vein, we clamp the renal artery, we put the kidney into the ice slush, and we excise the tumor with clear margins of at least a 0.5 to 1 centimeter margin, and within no time we repair the whole pelvic-ileal system and the kidney. So with this operation, the tumor with clear margin is removed and the rest of the kidney can be saved. What a wonderful thing to do. And nowadays, as we are seeing more and more patients with the smaller kidney tumors, everyone should be offered nephron sparing surgery. Now what happens to those patients who have undergone nephron sparing surgery? The kidney is saved, the contralateral kidney, even though it is not there or there, it doesn't make any difference to the patient, and the patient is very happy that majority of the kidney is been saved, which is so important for his kidney function. Some unfortunate patients present with metastasis, meaning the tumor would have gone to the lungs or brain or bones. Now, is there a role of doing surgery in these patients? Obviously, patients who have good performance status, patients who are having operable lesions, we tend to remove that primary tumor in the kidney, which is called as cytoreductive nephrectomy. And this is augmented with newer drugs which are called as tyrosine kinase inhibitors or immunotherapy to take care of the metastasis. Unfortunately, the metastatic renal cancer doesn't have good survival, but stage 1, stage 2, stage 3, even with involvement of the renal vein and IVC thrombus, have an excellent prognosis. So in all, we have done tremendous improvement in our planning treating kidney cancers in last 2 decades.